What if I told you that the very system designed to protect your health, to extend your life, might be setting you on a path of anxiety, unnecessary procedures, and a lower quality of life? It sounds shocking, I know. We're taught to follow the guidelines, to get the screenings, to trust the process. But after 70, the rule book changes. The one-size-fits-all approach to medicine, the very foundation of modern healthcare, starts to show its cracks. The tests that save lives in your 50s and 60s can become a source of harm in your 70s, 80s, and beyond. This isn't about ignoring your doctor. This is about upgrading the conversation. It's about understanding that your goals have shifted. You're no longer just playing for more years, you're playing for more life in your years. In the next few minutes, I'm going to reveal the 5 specific medical tests that you or your loved ones need to start questioning. This isn't information you'll find in a pamphlet at your doctor's office. This is the nuanced, evidence-based truth that often gets lost in a busy 15-minute appointment. We're going to pull back the curtain on the paradox of modern screening and give you the exact language to use to become a true partner in your own healthcare. And you absolutely must watch until the end, because the 5th and final test is the one almost everyone gets without a second thought, and it has the greatest potential to start a cascade of interventions that you do not want and do not need. 99% of people will just keep getting this test on autopilot, and they will be stuck in a cycle of worry for the rest of their lives. Don't be one of them. Let's begin. Screening paradox. Let's paint a picture. You get a reminder in the mail. It's time for your annual screening. Maybe it's a mammogram, or for the men watching, the dreaded PSA blood test for prostate cancer. You've been doing it for decades. It feels responsible. It feels like the right thing to do. So you go. You sit in the waiting room, you go through the procedure, and a week later, you get a call. They found something, a shadow, an abnormality, a number that's a little too high, and in that single moment, your world shrinks. Your peace of mind evaporates, replaced by a cold, creeping dread. The cascade begins. More tests, biopsies, consultations with specialists. Your calendar, once filled with hobbies and family, is now cluttered with medical appointments. This is the reality for millions. And here is the difficult truth we must confront. For many people over a certain age, often around 75, the relentless search for very early, slow-growing cancers can cause far more harm than the cancer itself ever would have. This is a concept doctors know as overdiagnosis. It's the diagnosis of a disease that will never cause symptoms or death during a patient's ordinarily expected lifetime. Think of it like this. Your body is a vast, quiet forest. As you get older, it's natural for a few tiny, slow-growing turtles to appear in that forest. They move incredibly slowly. They eat a little moss. They keep to themselves. They will live their entire lives in a small patch of that forest and never, ever pose a threat to the forest's overall health. Aggressive screening is like sending in a fleet of helicopters with searchlights every single month, desperately trying to find every single turtle. And when they find one, they don't just observe it. They declare it a major threat. They send in a ground crew to perform an invasive procedure to remove the turtle, which damages the surrounding trees, disrupts the ecosystem, and causes immense stress. And all for what? To remove a creature that was never going to leave its little patch of moss. The prostate-specific antigen, or PSA test, is a classic example. The US Preventive Services Task Force, one of the most respected bodies in evidence-based medicine, gives a C grade for PSA screening in men aged 55 to 69, meaning the decision should be an individual one. But for men 70 and older, they outright recommend against it. Why? Because the evidence is clear. Screening in this age group leads to a high number of false positives and the overdiagnosis of slow-growing cancers. These cancers, if left unfound, would likely have been carried harmlessly for the rest of a man's life. But once found, the pressure to do something is immense. This leads to biopsies, which carry risks of infection and pain. It leads to treatments like surgery or radiation, which have very real and life-altering side effects: incontinence, erectile dysfunction, bowel problems. These are not small things. They are thieves of dignity. They steal the very quality of life you were trying to protect. The same logic applies to other screenings, like mammograms. While they are crucial for younger women, the benefits become much less clear as a woman enters her late 70s and 80s, especially if she has other chronic health conditions. The potential benefit of finding a cancer that might take 10 or 15 years to become a problem has to be weighed against the immediate harms of anxiety, false alarms, and potentially aggressive treatments. So what do? You don't just say no. You have a conversation. You become an investigator of your own health. The next time a screening is recommended, you can look your doctor in the eye and ask a powerful question. Based on my personal health and my age, what is the statistical likelihood that this screening will help me live a longer or a better life? And then you ask the follow-up. And what are the potential harms? Not just of the test itself, but of the follow-up procedures if you find something. This shifts the conversation from a generic guideline to your specific life. It's about weighing the hunt for the harmless turtle against the peace and health of your forest. For many, after a certain age, choosing to let the turtles be is the wisest decision of all. Or good check. There are few medical procedures surrounded by more dread than the colonoscopy. The preparation alone is the stuff of legend. Yet, for decades, it has been hailed as the gold standard, a true lifesaver in the fight against colorectal cancer, and for people in their 50s and 60s, it absolutely is. Finding and removing a polyp is one of the most effective cancer prevention strategies we have. We're told to get one every 10 years, like clockwork. But what happens when you're 75, 80, or even 85? Does the same clockwork still apply? This is where the simple math of risk versus benefit becomes profoundly important and deeply personal. Let's be clear. The benefit of a colonoscopy is long-term. When a doctor removes a precancerous polyp, they are preventing a cancer that might have developed 10, maybe 15 years down the road. This is a phenomenal medical achievement. But you have to ask yourself, what is your time horizon? If you are 82 years old with heart disease and diabetes, is a medical intervention designed to prevent a problem that might occur when you are 97 worth the very real, very immediate risks you have to take today? For many, the answer is no. The major medical guidelines reflect this. The US Preventive Services Task Force recommends routine screening for colorectal cancer only up to age 75. From age 76 to 85, the decision should be an individual one, taking into account the person's overall health and prior screening history. After 85, they recommend against screening altogether. Why the change? Because the risks of the procedure itself start to mount, and they are not trivial. The bowel preparation, that infamous gallon of liquid you have to drink, can cause significant dehydration and electrolyte imbalances. For an older adult, particularly one with kidney or heart issues, this can be dangerous. It can lead to falls, confusion, and even hospitalization. Then there is the procedure itself. It requires sedation, which carries its own set of risks for an older heart and brain. And in rare cases, the colonoscope can perforate the colon, a life-threatening complication that requires emergency surgery. The odds are low, but they are not zero. Imagine you're planning a long journey across a river. In your 50s, building a massive, sturdy bridge that will take a year to construct makes perfect sense. The bridge will serve you for decades. But if you're already standing near the other side of the river, does it make sense to spend a year building that same bridge, especially if the construction process itself is risky? Or does it make more sense to use a small, reliable boat to simply get you to the other shore? The colonoscopy is that big bridge. It's a fantastic tool for a long journey. But as you get older, the focus must shift. The conversation with your doctor isn't about whether colonoscopies are good or bad. They are a powerful tool. The question is this the right tool for me right now? If you have a clean history of colonoscopies, the likelihood of suddenly developing an aggressive, fast-growing cancer is very low. You can ask your doctor, given my previous clear screenings and my current health, what is my actual individualized risk of developing colorectal cancer in the next 5 years? And how does that risk compare to the immediate risks of the prep and the procedure for someone like me? You might also discuss less invasive options like the stool-based tests, FIT or Cologuard. While not as comprehensive, they carry zero procedural risk and can be an excellent middle ground for surveillance. It's about making a choice that honors your present, not just a hypothetical future. It's about ensuring that prevention doesn't become a greater threat than the disease it's trying to prevent. Ahmad auf Sugar myth. For anyone living with type 2 diabetes, a single number often becomes the center of their universe, the A1C. The hemoglobin A1C is a blood test that gives a picture of your average blood sugar control over the past 2 to 3 months. For years, the mantra from doctors, diabetes educators, and pharmaceutical companies has been lower is better. We've been conditioned to see a number below 7% or even below 6.5% as the ultimate prize, the marker of a good diabetic. We chase it with diet, exercise, and an ever-increasing cocktail of medications. This relentless pursuit makes perfect sense for a 45-year-old. For them, tight control is about preventing the devastating long-term complications of diabetes, blindness, kidney failure, amputations. These things take decades to develop. But what about an 80-year-old? Does chasing that same low A1C number make sense? The medical community is now realizing with increasing clarity that the answer is often a resounding no. For older adults, the relentless pursuit of a perfect A1C can be a dangerous trap. The primary danger of aggressive, medication-driven blood sugar control is hypoglycemia, dangerously low blood sugar. And for an older person, a hypoglycemic event isn't just a moment of feeling shaky and needing a glass of juice. It can be a catastrophe. Low blood sugar can cause confusion, dizziness, and severe weakness. This is the perfect storm for a fall, and a fall for an older adult can be the end of independent living. A broken hip is a far more immediate and often more devastating health event than the complications from a slightly elevated blood sugar that might or might not develop 10 years from now. The goalposts have to move. The American Geriatric Society and other expert panels now recommend a more relaxed A1C target for many older adults, often suggesting a goal of 7.5% to 8.0% or even higher for those who are frail or have multiple health issues. The focus shifts from a number on a lab report to the well-being of the person in front of you. The goal is no longer perfect control. The goal is to avoid the symptoms of high blood sugar, like excessive thirst or urination, and most importantly, to avoid the dangers of low blood sugar. It's a profound philosophical shift from long-term disease prevention to immediate-term safety and quality of life. Think of it like driving a car. When you're young and on a long, straight highway, it's safe to push the speed limit a little to get to your destination faster. But when you're driving on a winding, unfamiliar road in a town you want to enjoy, you slow down. You prioritize safety and the ability to enjoy the scenery over raw speed. Your health journey in your later years is that scenic, winding road. Pushing for a super low A1C is like trying to speed down that road. You're far more likely to crash and burn than you are to get to your destination any better or faster. This is another place where your voice is paramount. If your doctor is still pushing for a very low A1C target, you have the right to question it. You can say, I understand the importance of blood sugar control, but my biggest fear right now is a fall. Can we talk about a blood sugar target and a medication plan that prioritizes avoiding hypoglycemia above all else? My goal is to feel good and stay on my feet today. This can open up a conversation about deprescribing, thoughtfully and safely reducing the number of medications you're on. It's a powerful concept that runs counter to the a pill for every ill mentality. Sometimes, the most powerful medical intervention is taking a medication away. It's about freeing yourself from the tyranny of a single number and reclaiming the bigger picture, a life that is safe, stable, and enjoyable every single day. That's the bone story. The fear is visceral. It's the image of a fall, the sudden crack, and the life-changing diagnosis, a broken hip. This fear drives millions of older adults, particularly women, to get a DEXA scan, a test that measures bone mineral density. And on the surface, it seems like a perfectly logical, proactive step. Find out if your bones are thinning, and if they are, do something about it. The test itself is simple and painless. You lie on a table while a machine scans you. The problem isn't the scan. The problem is the story we tell ourselves and are often told by the medical system after the scan. The result comes back and you're not in the green normal zone. You're not even in the red osteoporosis zone. You're in the vast murky yellow territory of osteopenia. Osteopenia. It sounds like a disease. It feels like a diagnosis of fragility. It's a word that instills fear and a sense of impending doom. And for millions, this diagnosis is the trigger for a prescription for a class of drugs called bisphosphonates. You've heard the names Fosamax, Boniva, Actonel. They are presented as the solution, the chemical shield that will protect your bones from fracture. But this is where the story gets complicated and where we need to look much closer at the numbers. Osteopenia is not a disease, it's a risk factor. It simply means your bone density is lower than that of an average healthy 30-year-old. By that definition, a huge percentage of people over 60 will have osteopenia. It can be a normal part of aging. The label itself creates what we call disease mongering, turning a risk factor into a medical condition that requires a prescription. And while the drugs can in fact increase bone density on a scan, their real-world effect on preventing fractures for people in the osteopenia range is often minimal. The relative risk reduction might sound impressive in a drug commercial, but the absolute risk reduction, your actual personal chance of avoiding a fracture because you took the pill, is often tiny. We're talking about preventing one fracture for every 100 or 200 people who take the drug for years. And these drugs are not without their own risks. They can cause severe gastrointestinal upset. More frighteningly, though rarely, they are associated with two very serious side effects: osteonecrosis of the jaw, where the jawbone essentially dies, and atypical femur fractures, where the long bone of the thigh can snap under minimal stress. The very drug meant to prevent a fracture can, in a cruel twist of irony, cause a different, more bizarre kind of fracture. So you are taking on these real, albeit rare risks in exchange for a very small statistical benefit. Does that trade-off always make sense? The true story of bone health after 70 is not primarily about density, it's about prevention. The vast majority of fractures are not caused by bones spontaneously crumbling, they are caused by falls. The single most effective way to prevent a fracture is to not fall down. This is the empowering alternative that often gets lost in the rush to prescribe. Instead of focusing all your energy and anxiety on a number from a DEXA scan, that energy can be redirected into a powerful, proactive fall prevention program. This means working on balance. It means Tai Chi or yoga. It means strength training to keep your legs and core strong, so you can catch yourself if you stumble. It means getting your vision checked, making your home safer by removing trip hazards, and reviewing your medications with your doctor to see if any of them are causing dizziness. This is where you can take back control. The conversation with your doctor changes. Instead of just passively accepting a prescription for osteopenia, you can lead with this: I understand my bone density is a bit low, but I believe the most important thing I can do is prevent falls. Can you connect me with a physical therapist or a program that specializes in balance and strength training for seniors? I want to focus my efforts there first. This doesn't mean you reject medication if you have true high-risk osteoporosis, but it does mean you refuse to let the label of osteopenia scare you into a pill that may offer little benefit. It's about building a body that is resilient and stable, not just chasing a better number on a scan. It's about investing in movement and strength, the true foundations of a durable, independent life. The raw numbers game. We've saved the most common, the most ingrained, and perhaps the most insidious test for last. It's the ritual of the annual physical. You go once a year, whether you feel sick or not, and the centerpiece of this ritual is the massive, comprehensive blood panel. Dozens of vials are drawn. A few weeks later, you get a report back that looks like an engineering schematic filled with acronyms: CBC, CMP, TSH, lipids, and columns of numbers. And almost inevitably, one or two of those numbers will have a little L for low or H for high next to them. They're flagged. They're outside the normal range. And just like that, the seed of worry is planted. Here is the secret that almost no one tells you. Those normal ranges on your lab report are, for the most part, not based on what is normal for a healthy 78-year-old. They are typically based on a bell curve of a much younger general population. As we age, our bodies change. Our physiology shifts. What is normal for you at 80 is not the same as what was normal for you at 40. A slightly lower kidney function, a slightly higher blood sugar, a subtly different white blood cell count. These can be completely normal, benign signs of aging, but the lab report doesn't know that. It's a dumb piece of paper with a rigid set of parameters. It flags your number as abnormal. This is the start of the diagnostic cascade, a journey you never asked to take. Your doctor, practicing defensive medicine and following protocol, sees the flag. We should probably look into this, they say. And so it begins. The flagged kidney number leads to an ultrasound. The ultrasound shows a simple cyst, which is almost always harmless. But now that it's been seen, it needs to be monitored, so you need another scan in 6 months. The slightly abnormal liver enzyme leads to a referral to a gastroenterologist who suggests more tests, maybe even a biopsy. All of this stems from a single, slightly off number that was found on a routine screen when you felt perfectly fine. This is what's known as an incidentaloma, an incidental finding that leads to more and more medical intervention. It's like taking a beautiful, reliable, 20-year-old classic car that runs perfectly and plugging it into a diagnostic computer designed for a brand new 2024 model. The computer would spit out 100 error codes. The oxygen sensors are a little slow, the fuel trim is slightly off. The catalytic converter efficiency is at 94%, not the required 98%. A mechanic following the modern rulebook would tell you the car needs thousands of dollars in repairs. But the wise old mechanic who knows classic cars would laugh and say, "That's just how these cars run. She's in great shape. Don't touch a thing." In our later years, we are the classic cars. Our bodies have found a new functional equilibrium. Shotgun-style testing, just for the sake of it, is a recipe for finding these meaningless error codes. This is not to say that blood tests are useless. They are essential when you have symptoms. If you are feeling unusually fatigued, have lost weight unexpectedly, or are showing signs of an infection, then targeted blood work is a brilliant diagnostic tool. The key difference is testing to investigate a problem versus testing to find a problem that you don't even know exists. The potential for harm from the latter is enormous. The anxiety, the cost, the radiation exposure from follow-up scans, the risks of invasive procedures. It all adds up. So, the final and perhaps most radical conversation to have with your doctor is about the annual blood panel itself. You can ask, since I'm feeling well and don't have any specific complaints, which of these blood tests are truly necessary for me this year? Are we just screening or are we monitoring a specific known condition? You can suggest, instead of doing the full panel, could we focus only on the few tests that are directly relevant to my health, like checking my thyroid, because of my medication, or my potassium level because I take a diuretic. This changes you from a passive recipient of a testing ritual into an active architect of your own care. It's about moving from a just-in-case model of medicine to a just what's necessary model. It's the ultimate act of self-advocacy, protecting not just your body from unnecessary pokes and prods, but protecting your peace of mind from the tyranny of the numbers game. Your life is more than a lab value. Your health is more than what fits inside a normal range. Which of these tests have you felt pressured to take? Share your story in the comments. Let's empower each other to ask the right questions.